about management of a patient with high-grade T1 disease. And these are patients that we're commonly faced with. And as you know, the natural history of high-grade T1 urethral carcinoma. The question is, should these patients be getting a BCG therapy, or they should be getting a cystectomy? So Dr. Chiala from Vets University will be arguing for BCG. But you can start, Chiala. Thanks.
Okay. Good morning, everyone. So as has been said, I've been arguing on the favor of the use of BCG on the non-muscle invasive bladder cancer, high-grade T1. I'm going to start with a quick recap in terms of actually the TNM classifications and staging of bladder cancer. This is a 2017 TNM staging, which mainly divided actually in terms of the primary tumor into non-invasive, muscle invasive, and then locally advanced tumor. So mainly our focus will be on the non-muscle invasive. So basically from TA to T1, but especially T1 today. So again, the same thing. Initially they use to actually have the term superficial versus invasive bladder cancer. And the term superficial is no longer used because as you'll see in these pictures, T1 can still invade your lamina propria, especially the muscularis mucosa, it still be a T1. Then whereas when there is invasion of the muscularis propria, then there is a detrusor invasion, then it becomes a T2, a muscle invasive. That's why the common noun nomenclature is to divide it into non-muscle invasive and then versus muscle invasive tumor. And then another quick recap on the WHO grading classifications. As all we know, it's been two grading classifications, the 1973 and the 2004/2016, slightly modified. So basically, we can still use both classifications. As you look at on the screen, the 1973 was based on 3 grades, well differentiated, moderately, and then poorly differentiated. The 2016 one was based on mainly the pan-LAM, and then the low grade and the high grade papillary urothelial carcinoma. And eventually, nowadays, they're trying to kind of put them together. And as you look at here, they try to reassign the grade 1 initially on 1973 as a pan-LAM and part of the low grade. The grade 2 and part of the low grade and part of the high grade, and then the grade 3 being reassigned as a high grade. So in terms of why do we need BCG, as all we know, it's about preventing recurrences and progression. But we need to know a bit of quick recap again on how the bladder cancers it forms. And then we know that it comes from mainly 3 pathways, from the normal urothelium to an hyperplasia leading to low-grade TA, papillary carcinoma, via molecular mutations and chromosomal aberration, that's all we know. And then from the normal urothelium, it can go into the hyperplasia and dysplasia, leading to high-grade papillary carcinoma. And then from the normal urothelium, it can lead to dysplasia and then a CIS, and eventually your CIS can mainly progress to muscle invasive, even metastatic. But the bottom line here, we need to look at, when you look at the low grades, it's more genomic stable, then is more prone to recurrences than progressions. When you compare to the high grade, which is more genomic unstable, which is made it to be more prone to progressions. And then to know about the probability of recurrence and the risk of progressions, we need to stratify those patients. So there are mainly 2 classifications. Either there is the EAU guidelines risk stratifications, and the AUA guidelines risk stratifications. I'm going to be mainly based on the EAU guidelines risk stratifications, which subdivides those patients into 4 risks: low, intermediate, high, and very high risk. So basically your low risk, you got your primary tumor, and then a TA/T1, low grade or G1, whatever actually grading actually classification we use, and a tumor less than 3 centimeters in diameter without CIS in a patient less than 70. Or either you got a primary TA, low grade tumor without CIS in one of the additional clinical risk factors. The additional clinical risk factor can be either the age, more than 70, or either is a multiple actually papillary tumor or the tumor size more than 3 centimeters. And then I'll come to the intermediate risk. The high risk is any T1 or high grade or CIS, and the very high risk when you combine your your T1, sorry, with a CIS or multiple recurrences of T1, or even when you got also any other variants, actually histopathological variants. And then the intermediate risk is anything that doesn't fit the low risk, neither the high risk, neither the very high risk criteria. So then it's just basically the same, but on the AUA guidelines, it's more classified into actually 3 risks: low, intermediate, and high risk. Basically mainly the same with the EAU guidelines, but the EAU guidelines, there is a subdivision on the high risk with actually the very high risk. But what is BCG? Basically, BCG stands for Bacillus calmette-guerin. It actually comes from an attenuated strain of Mycobacterium bovis, which was first developed at Pasteur Institute in France, in Lille, and then also since 1921 to prevent TB. And then it's been considered as the world's most widely used vaccine. And then that BCG has also an immunotherapy actions by stimulating an anti-tumor response. That's why it was first intravesically used for non-muscle invasive bladder cancer by Morales in 1976. And then thereafter has been many actually intravesical regimen that was developed, especially the one from Brosman from 1982. And then it's been also having various strains used worldwide. The common one that we use here, the first is the Danish strain, which is the 1331 actually strain. Just a quick history of the BCG from its discovery, you'll see, until the COVID-19. So then, as I mentioned, in 1921, the vaccine was developed. On the 1976 is where Morales used it intravesically for non-muscle invasive bladder cancer. And you can see even 2 years ago, they've been still on the phase 3 and 4 trial to start to investigate whether the BCG vaccine can even protect us against COVID-19. As you all know that the BCG vaccine is not only a single vaccine. From that single vaccine, so many strains has been developed. Basically on the loss of what we call the RD, which is the region of difference. There are 2 types. Initially, it was the 1 type, where we led us to have 2 groups of actually strain, the Russian one, the Japan one, and the Sweden one. But the actual one is the loss of region of difference in the type 2, which leads to the Danish actually strain, the Prague strain, even the Pasteur strain. But how does it work, BCG? The mechanism, it's poorly understood, but we know that the vaccine has some predilection for the bladder cancer cells by inducing human response similar to TB, characterized by the bladder wall expression of cytokine, and an influx of granulocytes and mononuclear cells and dendritic cells. And then induction of T helper 1 response, which leads to an anti-angiogenic and cytotoxic actually effects on the bladder cancer. That will understand why it's a limited response when the patient's immunosuppressed or immunocompromised. So basically, this is just a quick recap on how the BCG works. It's actually attached to the urothelium cells via fibronectin receptor or integrin receptor, and then it gets internalized by the bladder cancer cells. And it started actually producing a local and a systemic innate human response that will lead a chemokine and cytokine actually burst, which include the production of interleukin 6, 8, TNF, and then also which will lead to a human cells recruitment of granulocyte, CD4 plus, CD4-8 plus actually lymphocyte, which will induce a human-mediated cytotoxicity, which will lead to a killing of the cancer cells. But now, who gets the BCG? So the BCG, the treatment, those one who get the BCG, the CIS is all we know. We can't cure CIS by only endoscopic procedures. And then the BCG has been used in the treatment of CIS, and then it leads to 72 to 93% of complete response rate, with the reduction in the disease progression by 38% when you compare it to the other intravesical therapy. But not only on the CIS in the bladder, we can use in the CIS in the prostate, except in terms of scrotal, in case of stromal invasions. And then also we can use it in the upper tract by giving it retrogradely in the upper tract CIS. But in the low risk patients, there is no benefit of using it. As you know, as I mentioned in the previous slide, there is the low risk and they have more genomic stability. They are more prone to recurrence with less than 2% of progressions. But in all other patients with non-muscle invasive, additional BCGs always benefit in terms of reducing not only the recurrences, but also progressions. Obviously, everything has to be subject to risk benefit when it comes to toxicity. So for the quick rep on intermediate risk, it's more based on the clinician decisions to look at the risk benefit. And it will say that you can consider 6 weeks of inductions, either with mitomycin or BCG, but mainly the BCG maintenance for a year. There is really weak evidence in terms of mitomycin maintenance. We'll show it, I will show you in the next slide. And then in the high-risk patients, we use it in 6 weeks inductions, and then there is a maintenance BCG for at least 3 years, according to the SWOG actually regimen. But what does the guideline says? The EAU guidelines of 2021 suggest that when it comes to high-risk patients, to use a full dose intravesical BCG for 1 to 3 years, using the inductions of 3 plus the maintenance actually regimen of 3 weekly instillations at 3, 6, 12, 18, 24, 30, and 36 months, which is just a weekly BCG for 3 weeks, at 3 months, 6 months, and then every 6 months until 3 years. But obviously, when it comes to the second and the third years, you need to discuss with the patient and look at in terms of the side effects and look at also in terms of the BCG shortage. So then when do we give it? So according to the guidelines, we give it about 2 to 4, 6 weeks post-TURBT. We all know that we don't want intravasitions of the BCG, which can lead to a BCG sepsis. So then how do we give it? There is an induction phase and a maintenance phase. Then the induction phase, as I mentioned earlier, the weekly for 6 weeks, and the maintenance phase, it's a weekly instillation for 3 weeks, again at month 3, 6, 12, 18, 24, 30, and 36, that we call the SWOG regimen. But this medication, as all the medication, has contraindications. Then we have an absolute and relative contraindications. Absolute contraindications when the patient is immunocompromised. I think we understand based on the mechanism of actions of actually BCG, and then also the risk when there is a risk of intravasations, meaning traumatic catheterization, cross-hematuria. But also in terms of a patient with a previous BCG sepsis, normally the recommendation according to the guidelines to permanently discontinue the BCG. Also in case of total urinary incontinence, because the patient cannot retain the agents. And then on the relative contraindications, in the presence of urinary tract infections, liver disease, personal history of TB, and overall poor performance, status of the patients, and an advanced age of the patient. The reason advanced age, we know that with advanced age, patients are more prone to have underlying comorbidities, sometimes compromise status. But how does it work? BCG after TURBT seems to be superior in terms of preventing the recurrences in a non-muscle invasive bladder cancer, with a 32% reductions when you compare it to the other intravesical chemotherapy, such as the mitomycin C. But also there is a reductions on like 27% in terms of progression when it comes from a TA, T1, or even a CIS provided we use a maintenance treatment, and it becomes less effective when the patient is older. We know, as I mentioned, with advanced age, and there is no benefit to aid it actually with a mitomycin C. But we need to define what is the BCG failure. So according to the AUA guidelines, it's been defined, but whenever that there is a muscle invasive that is detected during follow-up. That's why they subdivided into kind of a four. They call it a refractory tumor, relapsing tumor, unresponsive tumor, and BCG intolerance. And you'll see here the relapsing tumor and unresponsive tumor, they're almost the same. They're defining the same as the recurrences of a high grade or G3 tumor after you've completed your maintenance actually course of BCG, despite the initial response. It comes more here on the refractory tumor. They say any high-grade tumor that appear during the BCG maintenance, either you got a T1 high-grade at 3 months, or a TA high-grade after 3 months, or at 6 months, after either reinductions or after the first course of maintenance. Or if you got a CIS that is present at 3 months and persists at 6 months. Why? Because they found out that more than 50% of the patients who had a persistent, with the presence of CIS at 3 months on BCG, when you give an additional BCG, this one can achieve a complete response to more than 50% of those patients. And then they define also the BCG intolerance when you have severe side effects that prevents the completions of actually the treatment. But I want just to pay attention here that when you look at when there is a low-grade recurrences during or after BCG treatment, they not consider it as a BCG failure. So it doesn't mean that all the recurrences should be labeled as BCG failures. But what is adequate BCG? They say when there is a completion of at least 5 of 6 doses of initial induction course, plus at least 2 out of 6 doses of second actual induction course, or 2 out of 3 doses of maintenance therapy. But now how to treat those BCG failure when it actually occur. So according to the guidelines, the EU guidelines of last year, 2021, they say when there is unresponsive actually tumor, BCG, either you use a radical cystectomy or that is the strong evidence, but there is a weak evidence in terms of bladder preserving strategy. But when it comes to a late BCG relapsing, if it's more than 6 months or more than 12 months for last BCG exposure, they say either you use a radical, either you recommend to your patient radical cystectomy or repeat BCG or the bladder preserving strategy. And when there is a low grade recurrences for initially primary intermediate risk, then either you repeat the BCG or intravesical chemotherapy for a year or radical cystectomy. That's what we'll see, sorry. On the EU guidelines, again, recommendations. This one, they say to offer full dose BCG installation for 1 to 3 years or radical cystectomy on the high grade. And you can see here that even on the guidelines, they're actually leaving it to us to decide either do we go straight for radical cystectomy on this patient high risk, or there is a full dose of BCG installation for 1 to 3 years. I'll come back with evidence at the end of my slides. So then what are the side effects? As I mentioned, as all the other medications in the world, it does have side effects. We can divide it into minor or major side effects. The minor side effect can be the patient can develop a flu-like symptoms, or the patient can have mild irritative bladder symptoms. There is what we call a Cleveland clinic grading and approach. I'm going to spare you the details, but just to mention, there are basically 3 grades. There is a grade 1, which is the patient develop moderate symptoms that last less than 48 hours. On the grade 2, the patient has more severe symptoms, mainly severe irritative voiding symptoms, hematuria, or symptoms lasting more than 48 hours. And then you got more severe, actually more serious complications where lead to hemodynamic changes, persistent high-grade fever, and then in that case, you need to withdraw the BCG therapy. Yeah. So then how do we currently prescribe it? We know actually the actual price of BCG by a vial, it's 782 Rand. This is according to, I think, Discam, checked the price yesterday. And then we need 120 milligram intravesically weekly. So then there is actually, which work up a total actually price of 3,128. I want you to keep in mind on the price, because when I'm going to discuss about the cost effectiveness, compare it to radical cystectomy, we'll see that the price, although slightly high, but when we have to compare it to the radical cystectomy, it still comes cheaper than the radical cystectomy, but that's when I'll discuss it at the end of my slides. So then it's been controversial in terms of what happened when you are facing actually shortage of BCG, or what happened when the patient has toxicity. They say that you can reduce the dose of BCG, but there are other studies that show that it actually, by reducing the dose of BCG, you're actually increasing the risk of recurrences, but there is no really, it's still debatable. Other studies are actually saying the opposite thing, doesn't have much impact as long as that you maintain the maintenance actually dose, the maintenance therapy for at least, for 3 years. And then obviously it's not, we're not gonna recommend it to lower the dose in the high risk patients. And then, by the way, the strain that we use is the SSI strain, is the Standard Serum actually Institute of Copenhagen, the Danish one, the 1331 strain that we use. How do you give it? Practically, we need to tell our patient to limit diuretic before the treatment in order to avoid actually dilutions, and in order also to reduce the post-void residual volume. And then also to reconstitute from the power with 50 mL of saline, and then to use it within 2 or 3 hours after reconstitutions, and to avoid contact with clinician actually skin, because it can lead to chemical dermatitis. And then we have to instill it by gravity. And then the dwelling time, it's 2 hours. There is limited evidence that support the turn side to side, because we know that sometimes we ask the patient to lie on the prone, supine, and then turn side and side. But side to side, there is limited evidence that support actually this technique of turning the patient side to side. And then to avoid fluoroquinolone, I find it interesting. I read an article which says that by giving fluoroquinolone at the same time you're giving actually intravesical BCG, it kind of actually inhibits the anti-tumoral actions of BCG. But again, it's still debatable. The other article that say you can give it, but the other one, most of them, they say no, they don't suggest actually giving it. Okay, so now what are the benefits of BCG? And the benefit of BCG overall, it's actually, I look at the survival, because, and then the quality of life, because the patient not only preserve his or her bladder, the sexual functions, there is a reduction of morbidity. And even if there is a recurrences, the recurrences occur within the bladder, and then there is less likely of metastasis, as I mentioned, survival benefit, and then possible protection against COVID-19. You remember on my previous slides, it's still on phase 3 and 4 trials. And then in case of shortage or failure, there's still alternative. But now, what about the evidence? The first actually evidence I'm pointing in, it was published 2 years ago in 2020 in the Scandinavian Journal of Urology, which actually look at in terms of they analyze the cancer-specific survival on putting the patients, the one group on initial BCG. All those patients had an high grade or high risk non-muscle invasive bladder cancer, and they look at in terms of long-term survival. Is there any differences? So they took about 3,862 patients. It was from 1997 to 2014. So it was a retrospective study. Then out of them, 687 at initial radical cystectomy. The other one benefit from actually the BCG. All of them, those patients had high risk non-muscle invasive bladder cancer. But what does it show? It shows that in terms of the long-term survival, they look at it on 5 years cancer survival. They find that on the group of the patient that was initially actually treated with BCG, it shows that it actually, the survival, was higher than on the group that the patient underwent actually a radical cystectomy. They look at it of 87 versus 71%. And then 78 patients die from cancer on the BCG group during follow-up versus 162 patients on the group of radical cystectomy. That's what they look at, and the conclusion was BCG had a better cancer specific survival than radical cystectomy during that actually retrospective studies. And then another actually evidence, they call it the Bravo study, which was published 2 years ago again. And then this time around, it was a prospective studies where 50 patients with high-grade non-muscle invasive bladder cancer were actually randomly assigned. 25 received BCG and the other 25 underwent radical cystectomy as an initial treatment. So then when they look at it, then they look at that, they say that they find out that 4 had, out of those BCG group, 4 had non-muscle invasive bladder cancer after induction, 3 at 4 months actually had non-muscle invasive bladder cancer, and 4 received cystectomy, and 2 had mets of the bladder cancer. But on the radical cystectomy group, 5 had no tumor, but 13 had non-muscle invasive bladder cancer on the specimen, and 10 had muscle invasive on the specimen. The conclusion were the patient, many of those patients were actually suitable for bladder preservations, and many maintained the pre-actually diagnostic quality of life. And then there is another debate and say that, but there is a shortage of BCG, what we can do. But then another study is evidence-based, confirmed that you can use it safely to use even a percutaneous vaccine. Then they say that it can be safely used for intravesical instillations. This one was actually a study that was conducted in 2019 between February until April. They look at 75 patients with 34 receiving intravesical BCG, 39 percutaneous BCG, 4 actually bladder cancer, urothelial carcinoma of the bladder. And then when they look at this, then they come up with the conclusion there is no significant difference. We're comparing those who receive intravesical versus those who receive percutaneous in terms of actually the safetiness. Then they say that they can use in terms of shortage of BCG, they can use, but it's still debatable, and percutaneous BCG. Then they say that it appears to be safe alternative to intravesical BCG during shortage. So then, and when I look at here, this is a recent article published in 2021 by Lam and Morales. They look at actually the pathway of BCG in terms of looking at from the time BCG was discovered and then introduced in the urology sector in terms of non-muscle bladder invasive bladder cancer. And then they look at it, then they come up, then they say the worldwide acceptance of BCG immunotherapy for bladder cancer. What other immunotherapy trials in malignancy were abandoned. And then with the 3-week BCG maintenance alone, not only is reducing actually progression in terms of non-muscle invasive bladder cancer, but also is reducing mortality in multiple centers randomized clinical trials. And then another one, that one was ASCO GU of 2020, just mentioning, I'm sorry for the, actually the slides, not really clear, but what he's saying is just mentioning what are the alternatives that we can use when there is a BCG shortage. Either they say you can either lower the dose, 1/3 of the dose. Another alternative, you can actually continue the maintenance for a year instead of 3 years. Or what you can do other agents such as gemcitabine that we can use. And then they say also as a last resort, you can do an early cystectomy. And then the last slide, it's actually what we call the Ivec. It's hypothermic intravesical chemotherapy for patients who does not respond to a non-muscle invasive bladder cancer. This is a retrospective study that was conducted from 2017 to April 2018. The aim was to evaluate the safetiness and the tolerance of hypothermic intravesical chemotherapy in patients with BCG refractory non-muscle invasive bladder cancer. 22 patients were included in the study. And out of those 22 patients, the patient received, 6 weeks installation of hypothermic mitomycin for a total of 6 weeks with a follow-up in 3 months. And they found it only 2 patients had progression to muscle invasive bladder cancer, and 4 of them had a radical cystectomy. And again, it comes on actually, they look at it and they say the efficiency remained about 27.3% in terms of the patients in case of where there is a BCG non-responsive to non-muscle invasive bladder cancer. But in conclusions, what's the debate today? The debate today is to know, is using BCG on the patient with T1 or high-grade non-muscle invasive bladder cancer under treating the patients, or by using radical cystectomy on those patients, we are over-treating the patients. So here we have to do, first thing we have to do is the risk stratifications of the tumor. And then we need to think, what are we treating here? Then we have to think about the disease recurrences and the disease progressions. But again, we need to overweight the risk. The high-risk patients must get BCG anyway. So then we have to keep in mind, there are still future novel agent modality of treatment of BCG failure. These are my references, and thank you.
Thanks a lot, Dr. Kabongo. It's an excellent presentation arguing for BCG for high-grade T1 non-muscle invasive disease. Unfortunately, the next speaker was arguing against, was arguing for cystectomy, has connection issues, I think, where he is, there's load shedding, so he can't connect even with his phone. But we'll make use of this excellent talk and just debate, discuss some issues around this very interesting topic, BCG and high-grade disease, T1, which you have really presented very well. Just a question from my side. So how do you define adequate induction of BCG? You know, I think you probably have the same issue yourself from your institution that, you know, when patients are supposed to come weekly for 6 weeks and sometimes, you know, they can't come, or sometimes issues with BCG shortage, you know, is it 3 inductions? Is it 4? Is it 5? How do you define adequate sort of induction?
Okay, thank you. Are you talking about in terms of induction?
Yeah, we can talk about induction, yeah.
Okay.
Or in fact, in any phase, how do you define adequate BCG?
Okay. 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 So in terms of adequate BCG inductions, so I mentioned it here, according to the guidelines, the EAU guidelines of last year, they define it as when you have completed 5, at least 5 of the 6 doses, as we know for the inductions, is every week doses for 6 weeks. So then if you have completed out of those 6 actually doses, you have completed at least 5 out of the 6, but of the initial induction, plus at least 2 out of the 6 doses for a second induction course, or if you have completed in terms of the maintenance, 2 out of the 3 doses of maintenance therapy. That's why the guidelines actually define it as an adequate BCG treatment.
Yeah, no, thanks a lot, Dr. Kabongo. Do you mind starting your video so that the audience can see you?
Oh, okay.
Are there any more questions for Dr. Kabongo from vets? More questions on the floor? We've got a question there from Professor Lazarus. Thanks, Prof.
Thank you, Sam, and congratulations to Dr. Kabongo. That was an exceptional, well put together, well-argued talk. Thank you very much for your contribution. I think you broke the record today, Dr. Kabongo. We've not had 80 participants before, so congratulations. 2 quick questions. On the slide that you're showing us there for BCG failure, it seems that BCG relapsing tumor and BCG unresponsive tumor are in fact the same. I keep always looking these things up and needing reminding what they are. Can you explain the difference there?
Thank you, Prof. I even asked myself the same questions when I was preparing the topic, because when I look at it, I mainly look at it on the guidelines, and I find it exactly the same. I have also the same questions in terms of, and I think I mentioned it as I was presenting actually these slides and saying that now they're putting together the relapsing and the unresponsive tumor as just the same recurrence of high grade after you've complete your BCG maintenance despite any the initial response. So I'm not too sure exactly, Prof, if how did they work it out? I'm not too sure exactly on that one. I just realized that it was just the same thing according to the guidelines from last year. I don't know if maybe someone else has maybe a better answer to that. I have also the same questions.
Maybe somebody has the answer. We'll just see if anyone puts them.
Yeah, I'm not too sure, Prof.
Yes. The second question, Dr. Kabonga, is did you come across any reading to suggest that Ivec, in other words, hypothermic mitomycin, might be equivalent in terms of efficacy to BCG? You spoke about the side effects, but I think a critical thing in the era of potential shortage of BCG, because we know that it's a drug that people don't make any money from, and hence it might be something that the drug companies stop making. So we do need alternatives, and hypothermic mitomycin would appear to be an attractive option, particularly having, as you've argued, the reduced side effects in this group of patients. But is it equivalent in terms of cancer efficacy?
Thank you, Prof, for the questions. I came up with that this article on the safety of Ivec, where they took 22 patients and then they give them 6 weeks hypothermic mitomycin, and then they follow them up at 3 months to look at. I think here they look at the efficacy, the way I understood actually the article, and then when they look at the efficacy, out of those 22 patients, they found that 2 patients has progressed to muscle invasive, and then 4 patients out of the 22 had radical cystectomy. That's why they come up with actually the conclusion saying that it was rather safe and well-tolerated treatment, and efficiency remained partial in terms of like 27.3% of the patient who experienced recurrences during the first year. But they say that this data should be confirmed with prospective multicentric studies. This is actually a study that was conducted in 2019. It was published in 2019, Prof.
Yeah, I think there are other studies, perhaps earlier than 2019, which showed it to be non-inferior to BCG. I think there are two relatively well-conducted trials with hypothermic mitomycin that did appear to show that it isn't inferior. That's what I have it anyway.
Okay.
Thanks, Dr. Kabonga. There's some questions on the chats. Dr. Goli just wants to know, because you mentioned the use of gemcitabine in place of BCG, he wants to know the efficacy in terms of recurrence or progression. Is it similar? Is it good? Is it better? Or is it less than BCG? Okay,
good questions. In terms of actually gemcitabine, which is, we know that it's actually alkylating agents. We use it also as an alternative in terms of actually mitomycin C. But in terms of the efficacy, I think it's an alternative. I mean, it's an alternative. It's, as Prof mentioned, there is a shortage of BCG. But when we don't have a BCG, I remember at Barra, they've introduced it, I think, a few months ago because of the shortage of BCG. In terms of the efficacy, I'm sure it's probably also as actually efficient than BCG, and obviously with probably less actually side effects than BCG. But those are actually studies further studies that need to be conducted to try to kind of confirm actually if it's really safer. But in terms of the efficacy, it's probably the same than BCG. And then they've been actually using it at Baragwanath, I think few months ago now, in the face of BCG shortage.
Yeah, thanks. There's a question from Prof. Mutambira. Sorry, Dr. Meki, our colleague from Zimbabwe. He was asking, what is the dose of percutaneous BCG vaccine? Because you also mentioned in your talk that you can give a vaccine. What's the dose for that?
Okay, to go and then take it on the specific actually studies. If they use it, not much here. I can't read it here. I'm not too sure exactly which dose did they use when they give it percutaneously, because remember, probably they dilute it, but I can't really know exactly the dosage they use percutaneously, fortunately, from the article that's actually I read here. Can't really look at it. Sorry. I can't really know exactly which dose did they use, unfortunately. I didn't look at it.
All right, now that I saw Dr. Mukendi had a question. Dr. Mukendi, it is.
Thank you. No, actually, my question was on the percutaneous BCG. So when I saw it on the chat, so I just lowered my hands. Yeah, that was my question.
Okay, no, that's good. So the other reason for this debate, Dr. Kabongo, was the fact that T1 is such a heterogeneous disease. It could just be a tiny sort of 1 centimeter lesion, and this, like we all know, it's just one step before muscle invasion. And we do know very well that patients that don't respond to BCG, they tend to have sort of poorer outcomes even at cystectomy. Are there any markers to sort of to find patients that would respond to BCG and sort of like ideally choosing the right candidate for it? Yeah, maybe the cystectomy guy was going to maybe talk about it.
Okay. In terms of the marker to try to find out, those are more going to high grade, or in terms of the BCG?
In terms of those who will respond to BCG, because if they don't, and they will not do very well in terms of the outcomes, even in cystectomy, because it's such a heterogeneous disease, because you can really have like a tiny lesion, you can have a 3 centimeter lesion, you can have like a 4 centimeter lesion, histopathologically, it can be quite variable to one disease. Are there markers to try and figure out who will actually respond to BCG that you've got? I don't know if you found something on that.
I haven't found much on it, but what I can say is probably it comes already from the high grade tumor itself. They look at more at tumor factors, and then saying that, we know that on the tumor factors, there are some actually chromosomal aberrations, or actually molecular marker that make them to be more prone actually to progressions. Like for instance, for high grade, the most important one I think is the TP53. They look at it, and then also we look at also the PTEN. But obviously there are tumor factors and patient factors. Like for instance, if you got a patient already with a high grade non-muscle invasive bladder cancer, but the patient is a slow N-acetyl transferase patient. So it make the patient already at high actually grade, or the high risk of progressions, because of when you look at is actually tumor factors and tumor related factors, and then the patient self-related factors. I think based on that, maybe then they come up then, because remember the guideline says, as you mentioned, in terms of high grade T1, non-muscle invasive bladder cancer, either we offer radical cystectomy straightforward, or either we give the patient the benefit of that and we go for the BCG. But I think what we do, if you know that these patients, like for instance, got risk factors like for against molecular risk factor, is a patient who got is an N-acetyl transferase, actually slow acetylation patient, and he got an high grade, maybe benefit, again, risk benefit, you can discuss with the patient and say, look at probably because of your actually underlying actually molecular problem there, you are more likely that you may not respond to BCG, and then maybe you are young, then we can offer you radical cystectomy. Then versus a patient who is normal actually N-acetyl transferase, for instance, or doesn't have mutation on the PTEN or the TP53, then you can say this patient, then I can give him the benefit of that and then start him on BCG.
Right, no, thanks a lot, Professor. This is the question again. Thanks a lot, Dr. Kabongo.
Okay.
I think it's worth talking a little bit about the dosage of BCG, and perhaps you can guide us here, Dr. Kabonga. I don't know anything about the percutaneous BCG, but certainly having some idea about the debates around intravesical BCG dosage is important. And obviously, some of the smaller print is also related to the strains. They're not all equal, but the dosage that we give in Cape Town is 120 milligrams weekly for 6 weeks as an induction. The trials have tried to look whether that full dose can be in fact reduced safely. And as I have it, 60 milligrams, which is half full dose, is not as efficacious as giving it the full dose. They also discuss whether reducing the dose or reducing the amount of times that you give it, that's also debated. And people recommend it's okay if you give a reduced dose to avoid some side effects, but you should give it as many times as is recommended for induction, in other words, 6. So I think those are some of the debates that we've gone through, and we still stick with the full dose for 6 weeks.
Thank you, Prof.
Dr. Kabonga, you guys use the same dose as well?
Yes, we use the 120 milligram. That's the same dose we use. We use 4 vial, and 1 vial comes on the 30 milligram. We give them, as Prof mentioned, and 120 milligram weekly for 6 weeks, the induction one, and then the maintenance one we give them. But obviously it comes in terms of cost effective, some of the patient, because the patient has to buy, they have to buy it. And then as you look at the costs, it's about 3,128 rand per actually a week dose. Then you can see it's quite expensive for the patient. So the problem that we encounter is more on the maintenance dose, where the patient can keep up. But we have few patients at the Jane and then Charles McClellan or Ellen Joseph Hospital here, where actually they managed somehow to have a maintenance dose, but they're not really complete. I think the patient that I know is in 24 months. So we'll have to see and wait up until he completes at least the 36 months as required by the SWAG regimen.
Got you with a question from Lisa. Thanks, Lisa.
Hi, morning, Dr. Kabonga, and congratulations on winning this debate with a little help from ESCOM. I just wanted to ask perhaps more your opinion on something which is a question that comes up often in our department, and that is, what one does with a patient that fails BCG because fails their first induction. It's always a question in which patient you should consider kind of reinduction, because I'm a little bit prejudiced because we've had a few patients who, for failed BCG, have really had horrible tumors when we finally do their cystectomy, although we thought that they had non-muscle invasive disease. One I recall recently even had metastatic disease. And it's quite strange because, when one looks at the definition of BCG refractory tumor, although one would think that if you have residual tumor, most of the definitions actually say if they have tumor present even after reinduction. So it does seem that, within the definition, many patients need to have a reinduction and fail that to actually be defined as a failure. So I was just wondering, in terms of your reading, what your feeling was in terms of the kind of patients that you would consider for reinduction in a setting where they have residual high-grade disease.
Okay, thank you so much, Doc. I think I'm going to go 2 ways. According to the guidelines, I'm going to stick in the guidelines, but to be practical on what we see on the daily basis when we are in front of the patients. I think Prof mentions about the cost, the cost actually of BCG. So to be in the practical way, if my patients fail a BCG, is a high-grade T1 non-muscle invasive bladder cancer, I'll offer him actually discuss with the patients. Obviously, there are patient factors and tumor factors. I'll discuss with the patients. If the patients fit criteria to have a radical cystectomy, I'll offer a patient radical cystectomy, because even if I give that BCG induction, I still have to give the maintenance. And then that maintenance for a high grade goes to 1 to 3 years. And then knowing our patients in terms of the cost, probably that patient won't be able to make it up until a year in terms of the cost. And then at the same time, if the patient has refractory BCG, then it put him actually Prof mentions on be more actually progression to muscle invasive. So to be practical, I will offer my patient a radical cystectomy. To be practical, because even if here they say when there is a BCG unresponsive, radical cystectomy, bladder preserving strategy, but those are the weak evidence, even on enrolling patients in the clinical trials. Because remember, those guidelines are in the first world guidelines. But on the daily basis, once we're in front of the patients and we know the reality of our patients, sometimes money is an issue. Then it becomes sometimes compliance is an issue. So then I will offer the patients, my patient, based on the criteria, patient factors, tumor factors, and then the environment where I'm working, I'll offer the patient a radical cystectomy for my patient who has failed a BCG.
Yeah, no, thanks a lot. Lisa, comments? Or
Yeah, no, I think, I don't think that there's an argument if somebody has got T1 high-grade disease that's persistent, but when one looks at the definition of the refractory tumor, for instance, if they still have CIS, in part of that definition, they have to have a kind of a re-challenge to kind of fulfill the criteria to be refractory. So that, I mean, that is a confusion. And I must admit, I mean, although one talks about doing cystectomies, patients are generally quite resistant to cystectomies, especially the older patients. Like, do I have to have my bladder out? And that always creates a problem, think, maybe you can kind of pull some of them back, I must be honest, I'm more, as you are, in favor of the cystectomy purely because, even if you're doing radical cystectomy for failed BCG in the CIS setting, 20% of them are going to have muscle invasive disease when you do their cystectomy. So that's a very kind of sobering statistic. But thank you very much. I think it's been a great presentation.
Thank you so much. Thank you.
yeah, no, thanks a lot, Lisa, for question and comments. Yeah, so the other thing, Dr. Kabongo, another way how we approach Lisa's question in our department is that, if someone hasn't had an adequate induction of BCG, and there's not a clear sort of guideline on this, but if they don't they haven't had an adequate induction, maybe say they had like 3 BCGs or 4 for whatever reason, and they sort of get lost in the system, and then they come back and you find a bit of a tiny tumor, say like 1 centimeter or 2, then in those patients, like you said, there's also patient factors, would be sort of like tempted in those patients to go and do a re-TURBT, and re-induce them. But in someone who's had an adequate induction, like 5 or more doses, like I would agree with you. I mean, the standard of care is a cystectomy. But in those with a tiny, small, high-grade T1 lesion in the bladder, but they've only had 4 inductions, we tend to just reset those and re-induce them. I also get quite anxious with this BCG, failure patients, because I also believe that, as the data suggests, they usually have like poorer outcomes. And as you said, there's the serious morbidity, as Lisa mentioned, with cystectomies. Patients don't really want their bladder out, and we tend to just try and re-induce those with the tiny lesion and incomplete induction. Yeah, I don't know if there's any more questions. It doesn't look like there isn't. There's more questions. Dr. Kabongo, this is really, I think, Prof, as you mentioned, yeah, I think in topics we've had in discussions about BCG, this probably is the best I've actually had in the few years we've been doing our webinar sessions. Yeah, congratulations, and like Lisa mentioned, by default you really won the debate because unfortunately the other speaker couldn't really present. Thanks a lot for the presentation. Thanks to everyone.
Thank you so much. Pleasure. Thank you. Thank you. Okay, bye. C'était